Yeah, please carry.
Good afternoon, everyone. I thank the organizing team for providing me this opportunity. So my case is dare to dare. So the case initially was a 75-year-old female who had a gradually developing pain in the right thigh over the last 2 years. The history was that she had a cemented bipolar hemiarthroplasty done previously in 2014 for a fractured neck of femur. So clinically there was tenderness inferior to the GT and there was some shortening. This is the X-ray. And so this was a broken stem with some varus remodeling, and cement restrictor is not there, so the cement has gone in a little bit more distal to the stem tip. And then she was taken up for a revision THR after the infection was ruled out. ESR CRP was normal. ETO was planned for the extraction, but intra-op the stem was quite loose, and the distal part we managed to get it out by using a window near the tip of the stem, and a reverse hybrid THR was done for her using a diaphyseal fit stem. So these are some intra-op pics for the primary surgery, and this is the extracted implant and the cement mantle. And I put in a Wagner for this, and like I was very happy at the time, said everything is going to plan, and this is the post-op X-ray, and so everything seemed to be going well. But then a wound check on post-op day 2 was dry, the patient was discharged. She was to come back after 5 days. For some reason, she came back on day 10, and I was in for an unpleasant surprise. While doing the dressing, I had this much of a hematoma collected on the tray. So it was a very disheartening feeling. It's a nightmare for us doing a revision. And then I thought it could be acute PGI or some acute hematogenesis infection, because this was into the second week of the surgery. So I did the culture and the CBC, the reports, CBC was within normal limits, ESR was 42, CRP was 6.3, and the stains showed gram-negative bacilli, and there was no evidence of any TB or any fungus. The culture had Klebsiella, and the sensitivity was there. So I admitted the patient for daily dressings and IV antibiotics, hoping that it will suppress.
No.
But then, after 2 weeks of treatment, it was not drying up. So I am left with limited options, and then I thought maybe I should go in and debride the hip and hope for the best. And then I went through some literature, so many papers showing good outcomes of DARE if done early in the first month of the surgery. And then the DARE was performed in the 4th post-op week. And this, like when I was incising, so much of fluid was coming out. And another nightmare situation. So then I had some stimulant, and tigecycline was mixed with according to the antibiotic sensitivity. And these are some intra-op pics. I opened the whole thing up, removed the bad looking tissue, put in stimulant beads wherever possible, and this was the post-DARE X-ray. And all the cultures and microscopy came back negative. The intra-op samples came back negative for any sort of bug, and the thing, again, things were going well, but only for about a week. And next week I do the dressing, I see this small area again discharging something. So at that time I did some blood investigations, ESR was 42, CRP was 39, TLC 7800, and then again I'm like, what is happening? So 2 weeks on from the first debridement, I thought last throw of the dice, another second debridement and VAC should be done. And one very important thing which happened was I discussed with my microbiologist that despite all the sensitivity and the culture showing the bug, the patient is not getting the benefits of the IV antibiotics. So it was suggested that it could be atypical mycobacteria, and ATT can be started for the patient. So I think this was a turning point in this case. And then second debridement I did along with the VAC, and after first session, after a week, again I put in for one more, because you can see at the bottom there's some fluid collection in the second pic. And then finally after 2 sessions of VAC and the dressings, the collections were declining, inflammatory markers were showing a downward trend, the wound was drying up and shrinking, and I did some secondary suturing from the bottom up to expedite the healing. And then it was all going well, and now at 9 months of follow-up, the patient is very happy, the wound has healed up. She has also gained weight after ATT, and this is her walking with some support at 9 months post-op. And this is just day before yesterday, I just called up the patient to send me her video, and she has a bit of waddle, but I think I'm happy with the outcome. Thank you.
Very well done, very well done. I think that's a very good example of how aggressively to treat infection, how you chased it. And I'm glad that you discussed, because this atypical mycobacteria is now becoming increasingly common. I think you have to specifically tell the microbiologist also when we send, and especially it comes back as culture negative. Some of us tend to be falsely taken aback and say, oh, happy, there's no infection. No, I think we should persist with it. Ask for extended cultures, ask to look for unusual organisms, and I think you did the right thing. And I think you were aggressive about it. Make sure the patient takes the complete course of ATT. I would say very well done. I think there's a message for everyone. Treat infections aggressively. You took it boldly for the second washout also. And I think there's no harm done to do that, because going after the infection aggressively is the best solution to this problem.
Did you do bactec cultures?
Pardon, sir?
Bactec cultures?
No, sir. The routine culture was
Buddhadev, even bactep sometimes fails to pick up the atypical. So what happens is, actually speaking, you need a special, the microbiologist does it and they pick up the atypical.
You need a low-flow serum slope special culture.
Correct. And they don't do it routinely because you don't ask for it.
If you don't ask for it. The problem with the low-flow serum slope culture is that your report comes 6 weeks.
6 weeks.
After the inoculation.
So you'll be very happy, till 2-3 weeks, so, nothing grown. Oh, I'm happy, I've eradicated infection.
So if you're getting recurrent discharge, then it's good to do a bactec culture. You get a report in a few days. So.
Yeah. Okay.
I think that's very well done, and I think that's a very good, very well presented also. Good round of applause for him.
Thank you, sir. Thank you.
Next we call Dr. Dharmendra Kumar.
Makes me happy all.
Pardon?
Humbly, as he told, the stimulant put the infection. Is have any role in infection? Stimulant.
Which one?
Stimulant.
Stimulant?
Beats.
See, if you put it there, it's good because the antibiotic beads. You can put stimulant, you can put antibiotic beads, either way. But that wouldn't have had a role in the atypical mycobacteria.
The rate of drug elution is higher with stimulant for two reasons. One is that the calcium sulfate granules, they actually dissolve and they release the antibiotic. The second is that, you see, you are not giving one big chunk of cement. So your surface area is increased several fold in a stimulant pellets. So that's why the intensity or the concentration of the drug is much higher. So personally, I've had very good results with stimulant. So I'm a great fan of using stimulant.
As long as you maintain that local MIC, which is good.
But you need to have the chart so that you know what are the antibiotics that you can use and to what concentration. Because the problem, what happens is, if with some of the antibiotics, the pellets don't form. Although the range is much broader because there's no heat destruction involved in this.
Yes, Dr. Dharmendra, please proceed.
Good afternoon, everyone. I'm thankful to our organizer who given me opportunity to present myself here. I'm going to present total hip arthroplasty in traumatic pelvic discontinuity with posterior wall defect. Before coming on to my first case, I would like to discuss what is pelvic discontinuity. Pelvic discontinuity is called as when the superior part of the pelvis is discontinued with the inferior part of the pelvis. It is called as pelvic discontinuity. It may be associated with also with the posterior wall defect, like in this case. So this is case of 1-year-old pelvic discontinuity, means transverse fracture along with the posterior wall defect, presented in a 40-year male patient. So there is three problems in this case. One is the discontinuity, second is the posterior wall defect, and third is the medial head subluxation. So what are options for dealing with pelvic discontinuity and the reconstruction of the posterior wall defects? So for pelvic discontinuity, we can reduce the pelvic discontinuity, means reduction of the inferior part to the superior part, and we can plate, after reduction we can do the plating of the posterior column. Then we can apply cemented cup on uncemented cup. For the posterior wall defect, we have femoral head as autograft and allograft and metal augment we can use to reconstruct the posterior wall. Femoral head has a limitation, like it can resolve in follow-up allograft has a risk of infection, and metal augments has, it is very costly implant and also has a risk of the incorporation into the bone. Another option for this type of injury is reconstruction case. So it provide only mechanical stability and very limited or very less osseointegration potential. Other option, we have a cup cage construct. It provides initial stability of pelvic discontinuity and later on provide biological support. Other option, we have a pelvic, this acetabular distraction technique for treat this pelvic discontinuity. It is generally reserved for the atrophic non-union of pelvic discontinuity, where the healing potential is very less. Another is custom-made implant. It is reserved for the very severe acetabular defect. In this, we take the CT and we plant patient-specific implant, and this the implant will be according the bone defect, and it also guides the where we can put the screws for the better fixation. So coming on to the original case, so this was a CT scan. This is a pelvic discontinuity. It is not united to superior part, it means not also the posterior wall defect. So here we use the posterior lateral approach to manage this case. First we do the femoral neck osteotomy, take femoral head to reconstruct the posterior wall, and then expose the acetabulum to expose the pelvic discontinuity part, and then also the expose and dissected the posterior wall area till the bleeding area come. Then we split the femoral head into two parts. Then we fix this femoral head. We try to reduce the pelvic discontinuity part, but because of fracture pattern, it was not reduced too much, because you can see the ischial tuberosity is very fracture, almost lost of the posterior wall, a very less part of the ischial tuberosity. So it was not reduced pelvic discontinuity part. So only we just do the reconstruction of the posterior wall with femoral head. First we try to temporarily fix with the K-wire, and then we apply the plate from acetabular dome area to the ischial tuberosity. And this plate is not holding this femoral head graft, but also taking care of this pelvic discontinuity. Then we ream the acetabular cavity in less anteversion position. Try to ream the intact acetabular part, not to ream this femoral head as a graft, and then put the acetabular cup for the anterior inferior and posterior inferior stability. So we must press fit the acetabular cup. And this is a 3-month follow-up X-ray. Femoral acetabular cup is little bit medialized because of non-reduction of this pelvic discontinuity part, because it's 1 year duration. And this is a 5-month follow-up. The further femoral acetabular cup was not medialized because we have done impaction grafting, and 5-year follow-up, this is patient function. But long-term follow-up is required to predict the final outcome of this case. This is young patient having pelvic discontinuity with acetabular defect, presented the 6 months since injury. This was managed with the femoral head graft and fixed with the screw only, because we find intraoperatively there is no much discontinuity, means there is no movement between superior and inferior part of the pelvis. So we just fix the femoral head graft for reconstruction of posterior wall. At the 3-year follow-up, patient having some myositis, but despite of this, patient is having reasonable good functional outcome. This is our last case. So this is transverse fracture with the posterior wall defect, having pubic diastasis, presented at 3 months since injury. This patient is managed with posterior wall reconstruction done with the femoral head and pelvic disc, and this plate is a posterior column plating was done. This plate is taken care of graft and the pelvic discontinuity part. And this is 3-year follow-up. And this is a 5-year follow-up. Patient having good radiological picture and this good functional outcome. So, conclusion of this presentation is posterior column plating is done for any instability of pelvic discontinuity. Femoral head graft as used to reconstruct the posterior wall defect, and impaction grafting provide biological support, and uncemented porous cup, preferably multi-hole, is used to treat this condition. Thank you very much. Last, we welcome IOCON 2020 in December, Lucknow. Welcome you all. Thank you very much.
Thank you. That was a good presentation. Actually, if you look at your cups, the first case that you put up, you put in a lot of screws. But one additional point, if you looked at the last case that you presented, you had put in screws inferiorly also.
Yeah.
So that is a good thing because it prevents the abduction type failure. Because if you only put superior. So one important point is, especially when you have such a large defect, pack it with bone graft, use the maximum size cup possible.
Yes.
And if you can get, if not the root screw, you can get the inferior screws because that will give you an additional point of fixation.
Yes.
But anyway, well done. It's a good series.
Thank you, sir.
Thank you.
Thank you, sir.
We call upon our next presenter, Dr. Harish Kumar.
Sir, I have one question, sir.
Yes, please. Just 1 minute. I think Dr. Chatterjee has to leave.
I request permission to
Sir, Dr. Chatterjee has to leave.
Because,
So he's
he has to
leaving.
catch the flight. So thank you very much.
Old neglected anterior hip dislocation. It is a superior type, pubic type dislocation. So anterior dislocation around the 7 to 13% of the all hip dislocation. The most anterior dislocation are inferior type, the superior type being less common. In which furthermore the traumatic neglected variety of anterior dislocation is rare. Mostly found in developing countries. In developed countries, rare situation, neglected variety. The reports on the management of neglected anterior hip dislocation are especially scanty, and few literature reports are available and mostly limited to the inferior type dislocation. So come to the case. My case is a 24-year-old male, history of right hip pain and disability, inability to bear weight since last 3 months. 3 months back, history of trauma. And patient remained immobilized for last, after 2 months of trauma, and after 2 months started walking with the help of a stick. This walk is non-weight bearing walk, and unable to do daily activities like squat, cross leg, and also his job. So on examining the patient limb, right hip was abducted in external rotation, femoral head was palpable entirely below the just SIS level and shorting more than 2 centimeter around, and there is a flexion and external rotation deformity was there. So this is the X-ray, first X-ray, in which you can see the dislocation. It is a 3-month-old. On CT scan, it is clear that it is the anterior dislocation, anterior type. So the challenges with the case is because the literature is a few literature available on this this type of neglected case. That's why there are the challenges with the case, conservative or operative management and operative what to do. So initially we give a high table skeletal traction along with the lateral traction. After 7 days of traction, there was no change in the position of the femoral head. So after 7 days, this is an X-ray. There is the same position. It was earlier in X-ray. So we did a first surgery. The first stage, the hip was approached anteriorly, harding approach. After exposing a neck, we could not able to reduce it, so we did excise the femoral head. It is a girdle stone arthroplasty that is recommended by the dislocations hip by the Nagy in 1992. So this is the X-ray of post-op period. Again, to overcome the limb length discrepancy and soft tissue contracture, we gave a 2-week skeletal traction. After that, we did a second surgery. The anterior, we curved the posterior. We planned the surgery for total evidence through the posterior approach. The incision was the same, which is curved posteriorly on upper side. Acetabulum was exposed and all fibratic tissues were removed. After the proper removing, uncemented acetabular cuff fixed, and femur side also the uncemented stem was. So this is a post-op X-ray. There was at the time of femur preparing, there was a small crack at the neck. That's why we put prophylactically the wiring. Otherwise, there was no crack at that side. So this is a immediate post-op rehabilitation was started, and non-weight was with the help of walker was advised as the pain subside. Weight was started after the 1 month of arthroplasty. So this is a after 1 month X-ray, and this is a clinical break at the 1 month of THR. And so this is a video of the patient.
So you have used, there's still slides? Okay.
Yes,
Fine,
sir.
go ahead.
Sir, in the literature, 21 cases reported or neglected in 13 studies. In 13 studies, and in these type of cases, open reproduction is difficult, and recommendation of salvage procedure like intertrochanteric osteotomies or modified extend arthroplasties. So these are the 13 cases, and the one study of youngs which denote the superior type dislocation. Only one study we found. So this is our case, in which they did the trochanteric flip osteotomy, and THR was not done at home. So conclusion in neglected dislocation are common in developing country, but the anterior dislocation superior type of is rare to see. Management guidelines is still extremely rare in the literature. The total hip arthroplasty with pre-op planning and such type of cases may give the optimal rate. Thank you, sir.
So I have few questions to you. You did the girdle stone through the Harding approach,
Yeah, anterolateral, Harding approach.
anterolateral. And then you did the posterior approach. Why was that done?
Sir, हमने hip by anterior sir, and recommendation by Nagi's anterior approach. Sir, in this report, sir.
No, forget the report. Why wouldn't you want to do the hip also through the anterolateral approach?
Sir, we are posterior surgeon in class. Sir, posterior side से हम करते हैं. Anterior surgeon से हमने try किया लेकिन सर उसमें reduce भी नहीं हो पा रहा.
No. Use the mic, please. Use the mic, please.
You did the girdle stone.
No, the mic is there in front of you. That's the mic.
Sorry,
Yeah,
sorry,
okay.
Yes, sir.
You did the girdle stone yourself.
Yes, sir.
You used the Harding anterolateral approach.
Yes, sir.
Then why did you go posteriorly in the second? Why you should
Sir-
have used the same approach?
Sir, at that time, we are planning only to do girdle stone arthroplasty, and where we were anterior approach, we are approached with anteriorly because the hip was anteriorly dislocated. So approach anteriorly, and we plan to reduce it. But we on OT table first time we are not able to reduce it. That's why we did a gradal arthroplasty. In second stage, we plan for the THR because we are a posterior approach surgeon in plasty. So that's why we did the posterior approach.
Okay, got it.
Very good outcome. Very good procedure. Can
Sir,
I
it
ask?
is only for 1 month, sir.
No, I know. So can I ask you one more question?
Yes, sir.
What is his occupation?
Sir, patient occupation.
Yes.
Patient is, is a shopkeeper. He's
What type?
on his shop, his general shop.
He owns a shop. He's depends on his.
Sir,
What
not
he-
a heavy manual labor.
No, not about manual labor. I'm checking what is his
He keeps sitting in the shop.
It's a chair.
in the chair.
Sir,
So because he's a 24-year-old in
Yes,
our country, I would still keep an option open to initially do an open reduction,
Yes, sir.
not do a girdle stent. Because see, what will happen if somebody comes to you with an acute or a 1-week-old anterior dislocation? Would you do an open reduction?
Yes, sir.
Correct. So you would require much more releases. The head might go into avian, that's okay. You can tackle that problem much later.
So that was our first aim to reduce it, but we are not able because it didn't.
If you look at your CT scan, the reason why it was not reducing, it was a
because
locked,
neck, head and neck.
it was a locked anterior
lip is
distal.
locked.
It was a locked
That's
distal.
right.
So if you release that, it would take a little more time, 4 months to 5 months. It would take, because it's 4 to 5 months. So if you do a complete release, in fact, sometimes it'll require a circumferential release. So you would be
Show
able
the
to
CT scan.
Show the CT
There
scan.
is impaction of the head there. So you see the head is impacted there in the
Impacted in anterior
anterior
lip,
part.
sir. Yes, sir. Yes,
Can
sir.
you see the majority of the articular surface is intact?
maintained.
Yes.
Can you see that?
Yes, sir.
So this would be, if you talk to a head salvage surgeon, this would be an ideal case to try an open reduction.
Open reduction.
So forget
So-
no, we are talking about THR, definitely you'd land up in THR, but the question is when. If you'd done an open reduction here, he would have got a 24-year-old, a shopkeeper, remember he's coming back that much more sooner for a revision.
You you didn't get the point. Dr. Anil is saying you should have open reduced this and waited. Maybe you would have given him few more years. Now that you have done a total hip, he might need an early revision. If you go to the
Yes, sir.
publications, the
Yes.
9th publication is mine. Neglected
Yes,
locked
sir.
obturated
Yes, sir.
dislocation, anterior dislocation of the hip. So that one is a neglected one where I've done a total hip arthroplasty. You understand?
Yes, sir.
So with this acute scenario, you can go in for an open reduction. That's what the message should be.
I think you can argue both ways. You've done a hip, it's come out very well, but you can argue also to do an open reduction and wait. But you have done this well. The question is you've done anterior and you've gone posterior.
Sir, mostly sir reports on the obturator type. Only one report I find out superior type pubic dislocation, and my dislocation was a pubic type. So, sir, there is no guidelines or some literature to what guideline have to follow.
Ultimately, when you're dealing with an anterior dislocation, whether it's a pubic type or an obturator type, the soft tissues that are involved are almost identical. So the release is required more anteriorly. And remember, the iliofemoral is gone.
Yes, sir.
So once you have dealt with that, you've dealt with all the releases, the reduction shouldn't be a problem. And it's a good execution of, and the plan was done.
If you're doing it in acute, THR if needed can be done in the second stage rather than going in for a girdle stone
Girdle
initially.
stone.
Yes, sir.
That should be the message.
Thank you, sir. Thank you.
Okay, very good. Now we have our last case, I think, by Dr. Ravikant. I think Dr. Ravikant, yeah, you stand between us and the lunch. Yes, Dr.
Yes, sir.
Prasad? He stands between us and the lunch. That's what.
Arthroplasty in periprosthetic fracture. The case seen is a 65-year female patient presented in emergency with a complaint of pain and swelling over mid-thigh and difficulty in standing and wear weight after slip from washroom. The past history of the patient is 1 year back lady had injury around the same hip region for which she is elsewhere operated. After 3 weeks, patient start bed wearing with support, but she has complained of mild pain over mid-thigh which is gradually increasing with the time. 1 month back, patient again got slip in washroom and re-injured. This is the X-ray of that time when she presented in the emergency. The diagnosis is made 1 year old elsewhere managed case of neck of femur fracture, managed with bipolar prosthesis with periprosthetic fracture with implant in situ. Fracture is Vancouver type B2. This is the classification of Vancouver. What wrong with the treatment? We can see again the X-ray.
Are you absolutely sure that the stem is loose? Because at least with the X-ray available, the proximal mantle, at least you look at zone 1, 2 and 6 and 7, it looks relatively well fixed. Mrinal, what do you think? Oh yeah, I think 1, 2 is loose, correct, yeah. 1, 2 is loose on the lateral side, correct.
There you can see it.
Yes, sure, go ahead.
We can see in the X-ray there is no sign of any cementing. And then we also have a question, is it an uncemented implant? Later on, when we opened the case, then we found a cemented implant is used as a uncemented. Now the pre-op planning is first of all we have to remove prosthesis, then the anatomical reduction of the fracture, fixation of the fracture and next implant what to be used. What we done in the OT, we have extension of the previous incision, posterior approach. Implant is loose, so easy to removal. Alignment of fracture is done by the clamp, circular wire and the control table. And the solution stem modular prosthesis is used. This is the intra-op images. And this is the post-op X-ray. The implant we use are SS wire to fracture reduction and the fixation. Control cable is used and the solution stem is used. And this is the walking video 1 month after the surgery.
What was the size of the solution stem used?
Sir, 14, sir. 14.
14.
1-4.
10, no, see there is 10.5, there is, what are the size available is not 14. Okay, thickness is 14, okay, good, right. Good fix, 8, 10, 12. This is how many months post-op?
Sir, 1 month post-op.
1 month post-op.
We have done just now, last month. Previous month.
Just a question, why did you want to use control cables? Why didn't you want to use plain SS wire?
Sir, I have a study somewhere, the SS wire is weak, not able to hold such a fracture.
No. SS wires will hold, if you do it well, SS wires will hold the fracture equally well. Each control cable is 5,000 rupees or 6,000 rupees.
Use double SS wires.
You double SS wire also, doesn't come to that. No, so don't go with the notion that, just a message for everyone, you don't have to use control cables. You can use SS wire, twist it well. You have 2 wire twisters and done. It does a brilliant job.
Yes, sir. Thank you.
You're making her bear full weight bearing at 1 month, I think.
Sir,
Are you afraid of the subsidence? Solution is
a
more
little
for
bit afraid,
subsidence.
sir.
Yeah, so don't,
So
the idea is
we will
she's
wait
fully
for
weight
the
bearing.
X-rays, some sign of union, then only we
I
start.
think this is premature weight bearing you have allowed her.
I think he's absolutely sure of the fixation. So you got a very good, so what size did you ream till and what is the size of the stem you put in? You said 10, 14,
Yes, sir.
correct? 10 inch. Yes?
Yes, sir.
Diameter. No, 14. What is the diameter? Length, okay. You ream till the same size or did you ream a little more?
Sir, same size.
Same size. How old is the patient? What was the age of the patient?
65 year around.
65.
65 years, sir.
Very good. Thank you.
Thank you, sir. We also invite our 9th UBO trauma course, was held in Safai Medical College on the 5th of November. I welcome you all. Thank you.
Thank you. Thank you, presenters, for an interesting case discussion. Thank you, Ronald. Over to Dr. Prasad.
Thank you, Dr. Anil. Thank you, Mrinal. And the history was significant. I think Dr. Anil was also nodding. When he said after surgery of bipolar, the lady was always in pain while walking, which was progressing. So probably there was a minor crack while the first inject surgery was done. And that way a trivial fall, a trivial injury led to a bigger fracture. So it's always prudent to check when you are doing a hip, and sometimes minor cracks can extend and become a bigger one. They can be checked at that time. And we all have seen it happening. So.
And it is an uncemented use, a cemented use and uncemented use. So obviously okay, sir. Thank you.
So friends, should we call it a day? We are going for lunch. Right? And thank you all the delegates who are still patiently sitting with us. I know it's Sunday and there was some panic about going. Even my Cawnpore colleagues, they all had to go. And there's another meeting in Lucknow also, so in the evening. So thanks for being here, and that shows whoever is sitting here, that shows his intent. And I'm pretty sure they are going to be the best orthoplastic surgeons of tomorrow. Thank you.
Thank you, Doctor.
So let's go, let's join lunch and enjoy our lunch.